So I'm Peggy Kendall, the Chief of Allergy Immunology, and it's my pleasure to present the 10th Charles Parker Memorial Visiting Professor Lectureship today. So Charlie Parker was really foundational to our division, and his grandsons, two of his grandsons are here today, Mark and Paul Bigg, representing the family. And many people in this room worked under Charlie Parker and can correct me of any of the things that I say that are wrong. You can also wait till later if you want to. So Charlie really did a lot of amazing work. He really defined the immunochemistry of penicillin allergy and developed the first and only valid drug allergy skin test and desensitization procedure. And we are still using his tests today that were published back in the 60s. He helped define the immunology of the hapten drug and IgE interactions. He first used anti-tumor conjugates for cancer immunotherapy, and this was back in the 70s, 60s and 70s, so a while ago. He used fluorescence quenching to measure antigen-antibody interactions. He expanded the role of radioimmunoassays in medicine. He was the one who demonstrated that slow-reacting substance of anaphylaxis was a metabolite of arachidonic acid, and demonstrated that the side chain on leukotriene-4 was glutathione. He demonstrated that cells that were deficient in glutathione could not make leukotrienes, and these studies led to greater understanding of mast cells. I just want to say that because of Charlie and his work, WashU is really sort of unique in the country in our understanding of allergy and immunology. And this is one of the few programs in the country where we have freestanding allergy immunology division. And so that foundational work was really important for the work that we're doing today and that we're launching into our future. So today, Dr. Kari Nadeau has agreed to come and give this lectureship. I've known Kari for about 10 years, we think, and she is just an incredible force to be reckoned with. She is just a force of nature. She is currently the John Rock Professor of Climate and Population Studies and the Chair of the Department of Environmental Health at Harvard, at the Chan School of Public Health. But I have known her to do lots of incredible work on peanut allergy and lots of other things in our field, but she's going to focus on her work in climate and population studies today. Kari and I were talking last night about how we were told when we were little girls that we couldn't be doctors. And we fought back against that. And, for those of you who are 30, you didn't live in that world. And I'm not telling you this so that you'll be sad for us, because it didn't make us sad, it made us strong. And when we both were defiant of what we were told, and we now take that fight to support all of you and those whom we mentor. And I want you to know, if you're younger, that progress has been made. And I am so glad that Kari fought the good fight, because she has done amazing things. Her CV is as long as my arm. She has 400 plus papers. She's done so much work that I can't get through all of it to tell you about it, but I'm going to tell you a little bit. She got her BS in biology at Haverford College, her MD and PhD in biochemistry and immunology at Harvard, internship and residency in pediatrics at Children's Hospital of Boston, and she started short tracking toward a hem-onc fellowship, but decided that was not for her, so she went to industry, spent 5 years in industry running clinical trials for this variety of businesses that you see here, was a chief scientific officer, a vice president, a medical director, and that was just in a period of 5 years. And then she decided that she wanted to do allergy immunology, and you probably know that immunology is a real big part of what we do, and she loved that part of it. She's done a lot of T-cell work. And after her fellowship at Stanford, she joined faculty in 2006, moved up the ranks there, became a full professor in 2015, And then in 2020, she added the Department of Epidemiology and Population Health and became affiliated with the Wuxi Neurosciences Institute. And then just last year, she moved over to Harvard, where she took on her current role. She's a member of the National Academy of Medicine. She's served on the Scientific Advisory Board of the U.S. EPA. I'm only telling you part of the stuff. Clinically, she practices allergy immunology in children and adults. She still practices a couple of days a month. And her research really spans, as I mentioned, a lot of areas of our field: immunology, infection, asthma, and allergy. And then she's been spending 30 years working on understanding how environmental and genetic factors affect the risk of developing asthma and allergies, with a special emphasis on wildfire-induced air pollution and its effects on children and adults, including firefighters. So I'm going to turn it over to Dr. Nadeau. Thank you for coming.
I'm so grateful to be here and also to have this honorific name of the Charles Parker Lecture. And I and all of you know that no one person can do any and all of these things. It really takes the team approach. And I'm so grateful for being part of that team and be a service as a leader. And importantly, having young people to be able to mentor and to be able to continue this field of work, because it takes many hands to be able to make discoveries. And I'll talk about some of the overarching issues around climate change and solutions today, because as many of you or your own families are dealing with across the country and here in St. Louis, there are factors that are increasing in terms of extreme weather conditions that will affect healthcare, will affect how we manage our patients, and especially in allergy, immunology, and asthma. And so I'll talk about that today and want to make sure that the objectives for today's medical grand rounds are to, number one, at the end of the grand rounds, to be able to discuss at least 5 connections between climate change and health outcomes, to be able to explain 3 solutions to climate change adaptation, and then also to give 3 examples of what a healthcare provider like ourselves can say to help their patients' individual health to be able to adapt to and mitigate against extreme weather conditions associated with climate change. So let me just start with some background. Many of you are already aware that because of the anthropogenic resources that we have and the use of fossil fuels, we have increases in greenhouse gas emissions. And it's not just about carbon dioxide, which stays in the atmosphere for a very long time and blocks infrared light to refract back on the Earth's surface, and that increases our temperatures on Earth, but it's also other gases like methane, nitrous oxide. We're learning a lot more about how long gases stay in the atmosphere, and that's a whole new field of climate science that atmospheric scientists and physicists are becoming more aware of. But as we see this energy resources being increased in greenhouse gases, we're expecting increases in temperatures. And right now, we're at about 1.5 degrees higher than we were. And you see this larger stripe, that's for the whole globe. We are on a trajectory right now at about 2.5 to 2.8 degrees centigrade above pre-industrial levels. The US, you can see there framed here in the slide in the smaller stripe level. Anyone can actually go onto this website called Find Your Stripes, and you can look at your area and you can actually find your own stripes for your own location. For that, we've gotten good heat monitoring in any given place on the planet. So let's talk about St. Louis. So here in St. Louis, the definition of a heat wave also varies, by the way, but in general, the definition of a heat wave is more than 3 days with over 95-degree Fahrenheit weather continuously. And so we typically will use that as an event to be able to track health outcomes. And you can see here in this graph that St. Louis from 1970 to 2020 has experienced increases. If you look at the color formation of the white to more magenta to more purple circles, that's increasing over time. What's expected now, if we don't reduce greenhouse gases, is that, for example, in St. Louis, you'll see a much higher rate of heat waves, unfortunately, about 44 days per year more in temperatures of greater than 96 degrees Fahrenheit. And that's not just St. Louis, that's around many places in the country. And why is this so important? Well, it's important for healthcare, but it's also important for economics. And when you look at some of the cost for loss and damages that occur with extreme weather conditions associated with climate change, and we've only talked about heat stress right now, When you look at the IPCC report, which is written by many rigorous scientists throughout the world, and look at some of the loss and damages that are incurred just in the US alone, the billions of dollars that have been spent in the last 20 years, about $1 trillion has been spent in loss and damages to extreme weather conditions. And about half of those extreme weather conditions are attributed to climate change that we know of. So when we think about breaking down how climate change affects health, we can think categorically because as medical trainees, as scientists, we like to make sure that we can categorize and understand the link and the attribution of any given climate change event and perhaps an effect on health, both directly and indirectly. And this is a nice resource that was given to me by my colleague at University of Wisconsin, Jonathan Patz, and it comes from a web page from the CDPH. But in that, you can see that different types of outcomes, drought, extreme heat, environmental degradation, changes in vector ecology. We'll talk about allergies and asthma today for the most part in immunology. But any one person at any one time in this planet could be affected by drought, extreme heat, food system impacts, and vector ecology all at the same time. So these issues concatenate. And in addition, not at any one time can these also be compounding, but over someone's lifetime. So we have to think about this as physicians holistically in our patients that are affected by many of these events simultaneously. And I'd like to break down these events. So many of these are affecting not just health of individual people, but also of the planet. And our health is inextricably connected to the health of the planet. So fossil fuel-driven pollution, worsening sand and dust storms, worsening wildfires, overflooding, temperature increases, changing patterns in infectious diseases. These are all happening, and we need to be apprised of how they are affecting individual health and public health. And again, with that inextricable connection with planetary health, as we think about extreme weather events that are happening and associated with climate change, with land degradation and deforestation, with biodiversity loss, this just increases the positive feedback loop with climate change and extreme weather conditions, which reduces our ability to have high quality lives here on Earth. And the WHO has been looking into this quite rigorously, especially for low to middle income countries and low to middle income communities around the world. And I was lucky enough to do a sabbatical at the WHO during COVID, and we were part of the WHO Academy curricula to be able to put together classes about climate change and health. And they occur now every year, so if people are interested in doing an internship, the WHO has internships after people graduate to be able to offer education to go as a community health worker in different parts of the world to look at resilient communities and building capacity for healthcare systems in especially low to middle income countries. There's been a lot of work in the healthcare sector about educating around climate change and health. This is a recent paper that was published in 2019 by my colleagues in Boston, and the New England Journal has done a lot of efforts in this area. But I want to point out that climate change affects everyone. It really is kind of the X-ray into the soul of a lot of already existing health inequities in our country as well as the world. But there are many high-risk groups, and that being many factors that are involved in those risks, including those that already have comorbid conditions, for example, heart and lung disease, congestive heart failure, as well as pulmonary disease. Older adults have a higher risk of many of these issues that I'll talk about today. Children, because of the compounding effects of climate change and extreme weather events, will have increased likelihood of having effects of climate change associated extreme weather conditions. And then especially underserved communities that are already inequitably exposed because they live near toxic waste dumps, or they're already inequitably exposed because of pollution exposure. And so because of that, they have a higher rate of having effects of health with extreme weather conditions. Importantly is the mental health effects of climate change, because it leads to displacement, it leads to communities being disrupted, and that affects social aspects of medicine as well. And climate change anxiety is becoming more and more an issue in our population, but importantly, it's affecting certain ethnicities more than others, and we need to be cognizant of that when we speak to our patients with anticipatory guidance and prevention type thinking. There are many people affected by climate change and extreme weather conditions. There are many vulnerable factors that I just spoke about. And importantly, there are different types of exposure pathways that can occur via soil, water, and air. And then our healthcare systems, and I want to really accentuate this in this slide, our healthcare systems need to be prepared. For example, when I was at Stanford in California, we had this terrible fire called the Paradise Fire, and their emergency preparedness plan had everyone going to the hospital. And unfortunately, the wildfire was ripping through the community at 1 football field a second. And the first building to be burned down was the hospital. So no one could go to what they thought to be the safe place. So these are the types of areas that we need to be preventative of and to think about ahead of time to be able to buffer the issues around climate change and how it will affect our healthcare system. So how does climate change affect the health of children in specific? And I'll talk about adults at the next slide. So air pollution unfortunately affects 2 billion children now. Almost 90% of children globally are exposed to levels exceeding 10 micrograms per meters cubed of PM 2.5. We have increased cyclones, heat waves, flooding, as well as other issues there that are associated with climate change. And unfortunately, in any child's lifetime now on this planet, they will be affected by at least one extreme weather condition attributed to climate change. And if anyone wants to know to what degree an extreme weather condition was attributed to climate change, you can look on a website called Climate Brief or Carbon Brief, and that's where climate scientists have moved forward with references and peer-reviewed literature to be able to model out what climate change event is associated with what extreme weather condition. So what about adults? Well, unfortunately, if we stay within the parameters of not reducing greenhouse gas emissions to the extent that we want to for the Paris Agreement, which is to get down to about 1.5 degrees centigrade from pre-industrial levels, we will be looking at death rates that are equivalent to the total death rates that are associated with infectious diseases right now around the planet. And so I think this is incentive for me. I know I don't want to be a Debbie Downer today and just give you bad news, but I want to make sure that all of this, as people in the healthcare field, really catalyzes us to do better, because this is what we're looking at if we don't be the change to be able to mitigate and adapt to climate change. So I want to give you some specific examples of climate events and how that affects health. For example, mental health, cardiovascular disease, kidney disease in particular, asthma, allergies, and infections. So for adults, there's been a lot of work now trying to understand. This was just recently published in Lancet Health in Europe for 2024. And here, what's interesting here is you can see the intersectionality in the social determinants of health and the effects of climate change on mental health. And that's not just in its acute form, but also in chronic issues, especially with displacement. When people are displaced due to extreme weather conditions, oftentimes it's women and children, and that's affecting mental health for pregnant women, for children over their lifetimes. Heat waves and mental health are something to be taken very seriously. You might have seen that already in your emergency rooms here at Washington University, but the increases in violent crimes, the increase in domestic violence, increases in suicide rates, these are things that heat waves are associated with, not only heat-related illnesses, but I'm really focusing on mental health here. The CDC has put together some really wonderful educational materials for the public, if those of you are interested. EPA, CDC has some great materials for patients if you're interested, and these have been vetted by many physicians and emergency room doctors. So now I'd like to move on to air pollution. As I said, air pollution affects many on our planet, and unfortunately in areas around the world, especially in the global south, we're seeing increases and rises in PM 2.5. And it's not just about PM 2.5. There's volatile organic compounds that are associated with air pollution that also affect our health. But you can see there the increases in air pollution-related deaths are about 8 million right now yearly across the world. And moving into wildfires, you don't have to deal with a lot of wildland fires here in St. Louis, but they do occur in places in the Midwest. We're seeing drier conditions because of the warming of our planet, and about 50% of our fires now around the U.S. are increasing because of climate change events. And you can imagine, because snow melt is occurring sooner, you have forests being drier, temperatures are rising so that you have a higher chance of being able to have any kind of inciting event for fuel ignition, for a forest fire. And because of that, we're seeing even different conditions of climate around forest fires, like tornadoes, as well as clouds that are just made up of wildfire smoke. And so this was a publication that was in the New England Journal, and I think it was a great review article for all the issues around wildland fire smoke. And as you can imagine, wildfire smoke isn't really wild anymore. Most of the fires that we're seeing across expanses in the US are also burning up commercial buildings as well as residential buildings. And so that includes your favorite shampoos, your detergents, your plastics, your paint thinners in your garage. And these are all going up in smoke and being breathed in by people. There is no safe distance from wildfire smoke. It can circumnavigate the world within 4 days. And we've seen that. We're doing a lot of chemistry on wildfire smoke in terms of looking at the fingerprint for each wildfire and what it contains. But most importantly is, what is it doing to the human body? And with that, even after 4 to 5 days of wildfire, you can see increases in stroke, increases in heart attack, increases in asthma, and we also see premature births in pregnant women, for example. So this is a paper that, if anyone's interested in looking at the data, this is from California. But as you could imagine, people that are in lower socioeconomic status have an increased risk of a lot of these health conditions. This is a paper that was done in the Journal of the American Heart Association to show increased heart attacks. And this was even after 4 to 5 days of continuous smoke. And typically wildfire smoke will stay in a community for about a week or more. So vulnerable populations also include farm workers, and especially here we're in the Midwest, and we deal a lot with the farming community. And farm workers, again, in that scenario where you can have more than one event affecting you, drought, heat stress, perhaps fire smoke, in our communities that include farm workers, they are unfortunately having more dehydration, more risk of kidney disease. And so there's a nice review that I just highlight there to think about occupational heat exposures, farm workers being one of the many occupations that are going to increase their risks of climate change associated events on their health. So this is where I want to specifically talk about kidney disease. This is a medical ground rounds lecture. Many of you deal with people with kidney disease. This is something that's increasing in the nephrology community, and an understanding of how climate change, dehydration, specifically for different ethnicities that have a genetic proclivity towards these types of dehydration events in their kidney function. And so this is now a new area where people are looking at chronic kidney disease associated with pollution exposure, dehydration, and heat stress. And this is a paper that was published to look at the association of heat index with change in eGFR within this particular trial that was done here. And you can see in terms of the modeling, the GFR is reduced in terms of increased heat. So this is a new burgeoning field, and for those of you who want to go into nephrologists or are nephrologists, I think this is something that we really need to look at more carefully with heat waves. In my field, in asthma and allergies, and in Peggy, and many of you might already be allergy, asthma, and immunology specialists, there's this concept of thunderstorm asthma. And it truly is a perfect storm. It relates to pollens being emitted into the air, and just like wild rice, where you have to pop the kernel in order to be able to get the rice out and soak it in water, what happens here is the pollens, which have a shell around them, get taken up into the clouds in thunderstorm, have moisture affecting them, they pop open and reduce more pollens, and then the electrostatic energy from a lightning storm will actually increase the protein exposures in these pollens, because the electrostatic aspects of the fires, the thunderstorms as well as the lightnings will then increase the antigenicity of the proteins that are then breathed in by anyone that's close to the thunderstorm. And so with that, in Australia and other parts of the planet, you have an increase in ICU admissions within hours. So again, talking about that capacity building within any given healthcare system, you have to be able to know when those conditions are going to occur for this perfect storm. Because in examples like Australia, they were not ready. So even though they had the knowledge and the technology to be able to deal with status asthmaticus and increases in admissions to a degree in the emergency room, there wasn't enough people and equipment to be able to deal with the increase in the populations that occurred into their hospitals due to thunderstorm asthma. And pollen is increasing as well. I wanted to note this, especially with the fact that this is the Parker Lecture and we're talking about allergies and immunology today. As many of you learned in elementary school, CO2, which is a greenhouse gas, is used by plants for their growth. And we are seeing increases in growth, especially those plants that are associated with allergies, like grasses, as well as ragweed. And so you see here, because of the warming of the planet, you're seeing ragweed growth in areas that otherwise would never have been conducive to conditions to grow ragweed, like southern parts of Denmark. Because of CO2, we also expect increased pollen production from any individual plant. And not only that, because of the fact that the globe is warming, our seasons for pollens are increasingly more in terms of February and March conditions compared to where they used to be in late March and April. And we showed that at Stanford. I was practicing there, and I saw that every season people were coming into me and saying, even though they were using the entire shelf of Walgreens and CVS to be able to try to decrease their allergies with antihistamines, their allergies were increasing over time. And so we looked at over a 17-year period to what degree the pollen season was lengthening. And so we found that actually it was lengthening by 8 to 9 weeks over that time period that I had practiced at Stanford. And so these are things that if you are looking at pollen exposures here around Washington University, you can track these types of time intervals as well. So infectious diseases are also on the rise. I want to make sure that before we talk about that, we talk about flooding. You're here near the Mississippi River. You've had elements of flooding, and building that into understanding to what degree floods will affect toxins in the water, fungal overgrowth, bacterial overgrowth, vector replication. These are things that a given flood can really affect people's health, as you all are aware of. It also affects vector-borne diseases and infectious diseases, and with the warming of the planet, we're also seeing changes in both parasite infections, viral infections, and fungal infections. And here, for example, I show you a panel of Lyme disease spreading. This is something that we worry about in New England, where when I trained in the 80s and 90s, it was something that was very much restricted to in the New England area, but you can see now it's spreading, and other areas of the world are increasing in dengue and malaria. So now I'd like to switch to solutions. I've talked a lot about the issues that are affecting health and how climate change is increasing those risks. And importantly, we need to have a balanced view of the future. There's a lot of things to look forward to in terms of positives. There's a lot more education about climate change and health. I hope that your medical school is also incorporating this into the first and second year education platforms. If anyone's interested, we have a whole curriculum on this. Our COP, our Conference of the Parties for Climate Change, that's run by the UN. Now it's in its 29th year, just occurring in Azerbaijan. Now health is mentioned much more frequently in that venue to be able to create solutions. 148 nations signed on to a Declaration of Health, but unfortunately it doesn't have a lot of teeth associated with it right now in terms of regulating that. And importantly, there's a lot more electronic vehicles occurring, a lot more reductions. The Inflation Reduction Act alone, you can see here on this graph, if it did not occur, you'd be looking at sort of that upper level of a trajectory of the extrapolation of that, red line there. But now with the IRA, with policies changing in the EU, in the European Union, we're able to at least get down to about 2.5 to 2.8 degrees centigrade. We were on a trajectory of about 4 to possibly 6 degrees centigrade. So already policies that we didn't think would have such an acute difference in the temperature reduction actually have reduced the temperature to a degree, but we need to even go further. And there still are many nations that are responsible for a large proportion of greenhouse gases, and infrastructure is a major issue that we need to make sure occurs, especially in the US and other countries. We're not at that net zero time point yet, and it's going to take a lot to get there, and we should be on a trajectory to be able to see that, as you can imagine. And we have the technology, we have the monies, we just need to be able to have the willpower and the behaviors to affect that change. So I was talking to Dr. Kindle last night in terms of if anyone's interested, you could go on Carbon Brief to look at the degree by which a given extreme weather event was associated with climate change. You can also go on this website called En-ROADS, and you can play with these numbers. It's really interesting. You can see the degree by which you can change an energy supply or carbon tax or change a given agricultural practice, to what degree that will reduce global temperatures. And a lot of policymakers are using En-ROADS now. It was made by a group at MIT called Climate Interactive. And I just find it really interesting because it gives me hope that solutions are possible to get us down to 1.5 degrees centigrade. So I want to focus on science-based solutions and talk to you specifically about how those can help our medical practice. And as a scientist and as someone that studies molecular biology and biochemistry and does a lot of single-cell omics, I love the fact that climate change can really help us as scientists understand from gene to globe. By understanding artificial intelligence, a lot of the work now we're doing with machine learning algorithms, we can really take what we've learned from satellites, for example, and project and model out to help communities prepare for flooding, for tornadoes, for earthquakes, for wildfires. And that's really helping us model to be able to reduce the risks on communities and public health. On the flip side, we're also looking at genes and looking at effects on single cells to be able to understand to what degree these events and exposures are affecting our DNA and affecting our health overall. And if we do understand targets, we can then potentially look at therapies that can reduce the risk to those health-associated issues with climate change. And I just wanted to give you some examples of what we're doing, and we're really excited to potentially, hopefully, collaborate with many of you if you're interested. You can have direct access publicly to some of these electronic AI modeling for different communities. We're doing this here in the US for wildfires. There's a website as well for indoor healthy buildings to look at. You can put in variables in your own buildings and see to what degree you can reduce health risks to climate change with given building materials and air filters. And then we're doing a lot of work on cooling pumps and different interventions. So we're happy to share this data. This is all publicly available, and it's really the work of many now that we're doing in the public health school and across our university in Boston. So in public health and environmental health, I'm an allergist and an asthma specialist and an immunology basic science researcher. But importantly, what I've learned a lot in environmental health, because it affects my patients, is how important it is to measure, monitor, and manage any kind of environmental exposures. And with that, the tracking is going to be critical. And so looking at solutions for adaptation and mitigation, in both of these solutions, I want to be able to give you some examples of what we learned through a program project grant that we very thankfully got from the NHLBI. And my colleague, Dr. Johnson, who's actually from right around here in St. Louis, she was able to put this together with me to be able to think about solutions on the individual level and the population level. So we work in Fresno in the Central Valley. We track volatile organic compounds. We've given everyone a smartphone, and we can actually track via EPA monitors how much individual estimate exposure they have been exposed to for PM 2.5, for volatile organic compounds, as well as other criteria, air pollutants monitored by the EPA. So you can kind of get a sense for this community because they're very close to Yosemite. They spend 100 days out of the year under the cover of wildfire smoke. They're an agricultural community. 1 out of 3 people do not have a job. The average salary is $35K. And importantly, there are many highways that run through this community. So there's a lot of air pollution and a lot of allergy. About 70% of the community has allergy or asthma. And so we look at this concept called the exposome. And I know we deal a lot with omics, and it tends to be a trend for being able to put omics at the end of any given word. But importantly, I think this is something that we need to think about holistically as an approach, not just from a public health standpoint, from a science standpoint, but also from an individual health point standpoint. So I like to think of exposome as everything and anything that could occur in anyone at any given time over their lifetime. And so that incorporates a lot, but interestingly, I'm looking at the exposome as it relates to climate change events in particular. And I want to give you, again, this hope and promise that solutions are on the way. And some of those solutions we've already known about for thousands of years. So this is a drone picture of Oregon, where a fire ripped through the community. Like I said, it goes through communities and forests at about 1 football field a second, which is what you're seeing there in the top panel. In the middle panel, you're seeing an area that is a Native American reservation. So there, the forests were taken care of with something called beneficial fire. At the bottom of the forest, people take care of the fuel there, and they burn it regularly to be able to reduce the fuel on the surface of the forest. And then the lower panel is where the forest was managed from the Forest Service. So you can see there to what degree prescribed burns helped that forest, as well as helped the community living around that forest. But many people were averse to be able to use prescribed burns and use, or otherwise known as beneficial fire. So what we did is use the Fresno community, again because there was prescribed burns occurring in Yosemite as a national park already by the Forest Service. And so we were able to show over time, compared to wildfires versus a prescribed burn, to what degree that changed their immune system and the air pollution in the air. And so this is a very small study. I didn't consider it to be that quote unquote rigorous. It still needs to be replicated with a larger group. But what we showed here is by taking blood during prescribed fire versus wildfire, we were able to show, as you can imagine, that the prescribed fire was less damaging to the immune system as compared to wildfires versus controls. And we also were able to do monitoring to show that less exposures occurred. And that alone was helpful to the Biden administration to be able to change policies, to be able to increase the use of prescribed burns, and importantly, increase resources so that when there is a beneficial fire, that we have enough firefighters to keep it limited. So again, being part of that change, as you think about how to help instruct your patients if there is increased air pollution, if there are increased fires and smoke, this mask that this child is using isn't doing anything to help her prevent air pollution exposure, for example. The masks to use are N95 masks, which we obviously know a lot about from COVID, but importantly is to reduce exercise, stay indoors if your indoors is filtered, and to be able to reduce that exposure. This is some data. There isn't a lot of data, but for those of you interested, there's some on making sure that you use N95 masks for air pollution. We learned a lot about N95 in COVID, but the same issues exist for air pollution. We need to make sure also that our filters are working in our homes and they need to be changed out frequently. So if you're talking to your patients, if there is a lot of air pollution, think about making sure that they know that there has to be high capacity of the filters in any given home. You can't just use one and expect that the air will be cleaner. We showed a lot of this data to our state representatives in California, for example. I'm doing the same thing in Massachusetts now, to be able to help the policymakers understand our science. And so we're doing a lot to bring science to policy. We showed this data, for example, to show that air filters actually do make a difference in filtration of air if they're used effectively. And we were able to get free air filters prescribed to our low to middle income communities. And so things like this, I think, are hopefully making a difference. We also showed the reduction in FEV1 for our asthmatics and COPD. This is a meta-analysis that was already published, and that also helped the governor's office give resources for clean air rooms across the state of California. But it's not just about solutions like that for adaptation, it's also about solutions that can be both for mitigation and adaptation, and that includes nature-based solutions. And as an allergist, we kind of have this yin-yang relationship with nature because, of course, a lot of plants and trees can increase pollens, but I want to show you some good news. And that is that if you can increase the tree cover of a city by 30%, you can reduce the temperatures by 1.3 degrees. I'm sure there's urban heat islands here in St. Louis, and that prevents premature deaths by 1/3. So again, 30% increase in tree coverage, reduction in premature deaths by 1/3. This is an epidemiological study done by my colleague Michelle Bell at Yale. But what does that mean for allergy, immunology, asthma specialists? Well, a lot of town councils, perhaps in meaning well, they planted one sex of a given tree in any given area because they wanted to reduce sort of ground coverage, and they didn't want to have a lot of fruit-producing trees. So a lot of towns will just plant male trees, but unfortunately, male trees will just keep putting pollen out in search for the females. And so from what I understand, and I'm not a tree ecologist, but unfortunately, those places that haven't planted in enough frequency both sexes of trees for any given tree, if they haven't planted them together, there's more pollen production. So what I'm hoping is you can all now be the megaphones that you already are and let your town councils, let city councils know if they're going to plant trees, just plant them with the right species, with the right gender to be able to reduce pollen exposure. And on that note, I also want to give you some good news that you can also work with your local communities. We worked with our local high schools to ask them to be able to go to town councils, talk about reductions in greenhouse gas emissions, and specifically in their school buses to reduce emissions. And we did this in Fresno because the community, again, was really worried about their air pollution levels. And we showed the town council in Fresno this great example of LA, where they were able to reduce emissions over 50 years, and we could actually show, and this is not us, this is another group out of USC, University of Southern California, showing the increase in lung capacity over time when reduction in pollution in any given area occurs. And so we were able to show the town council in Fresno the importance of electronic vehicles. And luckily, the EPA gave many inducements over the last 4 years towards switching diesel buses to electric buses. And we were able to show this data from a postdoc who does health economics research at Harvard School of Public Health. And net, just based on mortality risk alone, which is highly conservative, there's a net savings of about $270K per bus that is switched out from diesel bus to an electric bus. And that's just based on health benefits alone for mortality risk. And in general, for every dollar spent in reducing greenhouse gas emissions, and this is specifically knowledge for you as healthcare providers, you receive at least $6 out in co-benefits, and that's within a 28-day period. By reducing greenhouse gas emissions, reducing school bus emissions for diesel exhaust, that improves asthma in that given area of the community, as well as the people that are riding that bus and the bus driver by 30%. So again, these are palpable, tangible, even within 30 days. So what is St. Louis doing? I went on your website, looked at some of the implementation of climate change solutions occurring right here in your backyard. You've actually had a climate vulnerability assessment done in place since 2018, which is great. Kudos to St. Louis. There's a lot of participation at the Bloomberg Cities program, which is excellent, and a lot of mayors are talking to each other about how to prepare for climate change. There's decarbonizing efforts occurring here, especially your cycling initiative. And there's a lot of social programs already that distribute air conditions and are setting up cooling centers around your city. But I also want to make sure that as we think as healthcare professionals to get our own house in order. Unfortunately, healthcare and the healthcare industry account for 9% of all greenhouse gas emissions in the US. So we really need to be better at our own institutions, at our own buildings, and make sure that we're not contributing to the very same issues that are affecting the health of the people that come into our healthcare clinics and hospitals. And so with that, there's a whole movement towards going net zero. The United Kingdom started this, the National Health Service, because there was a horrible case that occurred in England where a young child died because of where she lived in London, and it was attributed specifically to air pollution and her asthma-related death. And so with that, the UK started to put a net zero healthcare policy together, and luckily 124 countries now have signed on to this, including the US. And as you can imagine, if your healthcare system goes to zero, all the supply chain has to go to zero. So now, because the UK is doing this right now, 30,000 companies have had to make a supply chain that is green, that is ecologically friendly. So hopefully we can also reap the benefits of that, because it's been mandated by countries like the UK. And so this is one of my last slides to show you that we can all role model better. There are many organizations involved in decarbonizing healthcare systems. The National Academy has put together an amazing series on this if anyone's interested. I put together some websites at the end of this lecture if people are more interested, but these are the websites that I've spoken about in my talk today. For those of you who run laboratories, there's also My Green Lab to be able to reduce water use and to be able to think about how to reduce the energy expenditures in a lab as well as in our clinic and reducing plastic use. So the next steps, I'd love to be able to collaborate more with your university and medical center to be involved more in programs with disease surveillance to help public health as well as individual health, and to look at how we collect data, harmonize data, and to work with organizations like the national academies, like the UN, like the WHO, and to develop health indicators as we think about solutions and what indicators we need to look at both on the acute and chronic level to think about testing solutions and whether or not they're working, and if they're not working, which communities they're not working in and how we can do better. Finally, recommendations for change: transition to healthy, sustainable practices, remove fossil fuel subsidies, talk to communities, increase access to healthy transport, strengthen the public health care system, invest in health recovery and prevention, and green areas, and build more infrastructure. And I know this is easier to say than do, and there's a lot of issues around just transitions and economics, but I'm hoping that some of these comments helped you provide data for which to speak to your patients as well as policymakers. So for summary and next steps, I discussed the effects of extreme weather conditions and climate change, and I gave you some examples for solutions, both adaptation and mitigation. I encourage you to talk to your patients and how extreme weather conditions affect them. Talk to your state and about offering filters, for example, that are covered by health insurance, if that's not already here in Missouri. Talk to your patients about how to use steps to reduce air pollution exposure, if that's an issue on any given day, and then try to be role models for sustainable practices. So I want to thank you for your attention, and none of this could have happened without funders and without families and participants and communities. So thank you.
So we have time for some questions.
Fantastic talk. Thank you so much. I have two questions. So one would be, depending on the state, there's variable friendliness for these policies. What have you found to be an effective means of communication to, get investment and thinking behavior? And number two, with prior, other countries trying to industrialize, and we were not held to the standards that we're trying to hold them now. But what do you tell them, or how do you support them to cooperate in these endeavors?
It's a great question, and I'm only one person here, and I'm not a, oh, thank you. The question was, what policies, what is the approach to changing behavior and changing some of these policies to be able to have solutions to climate change? And then for specific countries that are being affected, how have we dealt with that? Is that correct? Did I get that correct?
Yeah, the second one was more of countries trying to advance production and get more economic wealth.
Right.
And we got to a point where we were not held accountable.
Yes. Yes, exactly. This is this whole concept of just transition and environmental justice as we think about the balance of the economics. So these two questions are very important. Again, one being how do we potentially change policy and work with communities, and another being about a question on how do we deal with these just transitions with countries that are trying to increase their economic capabilities and improve their populations as we think about reducing greenhouse gas emissions. So on the first side, what I'd say, and again, I'm also new to this, that talk to your local communities. So many of these solutions are hyper-local, and that we need to learn from the communities first, and we can be that voice because you're talking to patients. You can ask them, what are the issues? You don't have to use the word climate change. You can actually say, what extreme weather condition affected you? What happened during that heat wave? So I'd be very concrete in talking to communities. And what helps me is if there's a community member or if there's a school that wants to be really involved, we'll work together and go to the town council. So I never want to do that alone. We do it as a group with a multidisciplinary, diverse group of people to be able to then affect change. And it takes time. The first time we went to the Fresno Town Council, for example, and asked them to replace their diesel buses with electric buses, they laughed at us. And it took 5 years to get there. So it's also about perseverance and tenacity, which takes time and energy, but it's worth it when it happens. On the second question, that is a tough question. There's a great book called Finer Future. And if you're interested, there's this whole new aspect called well-being economics, which really challenges the current economic growth model that we have and what we could be doing in the future to balance this dichotomy between those nations that want to improve their economy and that those nations that have been responsible for most of the greenhouse gas emissions. And unfortunately, those other countries are suffering the most from the global climate change. Does that help answer your question? Okay. Thank you.
That was a great talk. Thanks so much. So you demonstrated the big impact of healthcare, on greenhouse gases. Are there specific interventions that hospitals and health systems really should target as major interventions to reduce their impact?
That's a great question. So the question is, with the fact that in the US specifically, about 9% of the greenhouse gas emissions are associated with the healthcare system, clinics as well as hospitals, there are a lot of interventions. And then when you think about what's going to get the most bang for your buck, right? Where are you going to be able to reduce greenhouse gas emissions right away just from small changes that are economically feasible within our burdening society and healthcare costs? So what people have done is work with anesthesiology departments right away. Like there's some really key things to be able to change gases like nitrous oxide, because that's a very potent greenhouse gas. And so things like that are occurring at sort of the surgery or the anesthesiology departments. Those are helping. The other big implementations that are occurring for some of the healthcare systems that have been successful in reducing their greenhouse gas emissions is changing their energy source to like a solar farm. And so what a lot of hospital systems now are doing, at least in our local areas in Boston as well as in California, they're just basically switching their electric source to solar farms or wind farms compared to electricity that's generated through fossil fuels. So those are things that are dampening the greenhouse gas emissions. The other big component that's also changing, and again, you run a hospital here and you run a program, so these suggestions obviously need to be tested for different scenarios here at WashU. But one thing that we tried at Stanford was just using disposable gowns and switching them to the old-fashioned gowns that we autoclave, that we basically sterilize. And that didn't increase infectious diseases. It actually reduced them. And interestingly, we were able to save a lot on plastic and disposable gowns. So those are just some things, but that was actually something the medical students did. But we tested it. So we used every single time there was an intervention that was associated with a QI program in our hospital, we made sure that we could actually test how well it worked or how well it didn't work. Does that answer your question? Okay. Thank you.
I just want to make a plea for internal medicine and primary care medicine. Over my career, I've seen the loss in California, San Diego. There are no private internal medicine doctors in San Diego County. Everybody's employed. And for a long time, I have to raise the issue of hysterical blindness in the medical community, where the clinicians see things, but the research community
It's a very good point. And forgive me for not knowing, but in the curriculum in first and second year here, do you have some aspects that are threaded through for extreme weather conditions and how that affects certain aspects of health and internal medicine, or? Okay, okay. Yeah, these are, I think we as physicians and as scientists, we're having to be very nimble and deal with different aspects of medical care that we need to be apprised of and educate ourselves beyond just medical school, like to be constantly actively curious about these. And the literature, sometimes we don't have enough access to it, or it's hard enough to read given how many patients we have to see. So I hear you, and there's a medical society, if you're interested, for climate change specifically, that is basically condensing a lot of the knowledge to be able to use it effectively as physicians treating patients.
So I do have one question.
Sure.
So you are doing a large-scale data collection.
Yes.
Garbage in, garbage out, good stuff in, good plans out.
Absolutely.
Tell us something about the large-scale effort of data collection and how we might help with that.
I think many of you, you are probably connected to epidemiologists as well as data scientists, or you also might be data scientists and epidemiologists yourselves. We rely on data every day in the electronic medical record systems. There are certain data platforms that could perhaps not be accessible to us in the near future. So if you do rely on databases like exposures, like NOAA databases for climate change or climate science or extreme weather conditions, NHANES databases, Medicare and Medicaid databases, please let me know, because we are really trying to make sure that we can download a lot of that information with a cloud and save it for universities and medical schools to be able to have free access to in the future. So please let me know afterwards. We want to be able to be proactive in making sure that we have the best data that is accessible to us to be able to really think rigorously about how to do our science and how to track many of these issues over time. Thanks for asking that question, Peggy.